Good morning, everyone. I'm going to start with give you some important recommendation from 2017 ESVS guideline for measurement of the carotid artery disease. Let's start first with asymptomatic carotid artery disease. What the recommendation? If the carotid stenosis is less than 60%, or you have an occlusion or near occlusion, then best medical treatment is the way to recommendation is to go. If patient has 60 to 99% and he's asymptomatic, we used to recommend surgery. But now they want us to look at the life expectancy. If it's more than 5 years, if he has favorable anatomy, and if he has one more than one feature suggestive higher stroke risk on BMT, then if he has any of these, then they recommend to do a surgery as a first choice and stent as a second choice. But what we mean by a high stroke risk, this is what they mean. If patient has any of these, then asymptomatic recommend to do a surgery. If he has a contralateral TIA or stroke, or on cerebral imaging if he has ipsilateral silent infarction, on ultrasound guide imaging if he has stenosis progression more than 20%, if he has a HITS, if he has an impaired cerebral vascular reserve, large plaque, coalescent plaque or increased juxtaluminal plaque area, or an MRA if you find intraplaque hemorrhage or lipid-rich necrotic core. So if patient has any of these, then it recommend to do surgery for asymptomatic patient. What about if patient symptomatics? Then again, if it's less than 50% or has an occlusion or near occlusion, then PMT is the way to go. But if he has 50 to 99%, then the first choice to go is surgery and extend to be reserved only for high-risk patient. What about the timing? When we do a surgery if patient symptomatic, it's recommended to do it within 14 days. And if you're going to do it, recommend to do a surgery, not a stent. And the level of the evidence is 1A. What if patient has an acute stroke and he has a carotid stenosis? How soon we need to do a surgery after a stroke? It depends. If they want us to wait, if patient has a disabled stroke with a rank score more than 3, if he has an infarction exceed 1/3 of the ipsilateral middle cerebral artery, or he has an altered consciousness. If patient has a stroke in evolution, then it's better to do the surgery as soon as possible within 24 hours. What about intervention after thrombolysis? How soon we need to do carotid surgery? It depends. If patient showed a rapid recovery, neurological recovery, and infarction was less than 1/3 of the ipsilateral middle cerebral artery, and he has 50 to 99%, then it's better to do it within 14 days after thrombolysis. What about surgical technique? Should we use shunt or not? They left the choice between doing routine shunt or selective or never shunting to the discretion of the surgeon. What about using patching? It's recommended to do patch angioplasty versus just primary closure. What about eversion technique? Eversion technique is recommended better than primary closure, but if you have a choice between eversion technique and patch angioplasty, they left that to the discretion of the surgeon. What about kink? If you have patient has a kink and asymptomatic, it's better not to do it. If patient has a kink in the internal carotid artery and symptomatic, then you can do a surgery, but this after multidisciplinary team to be sure that his symptom coming from the kink. Bypass surgery for internal carotid artery occlusion is not recommended. What if patient has carotid surgery or stent and he came with a recurrence of the occlusions? It depends. If he's symptomatic and he has occlusion between 50 to 99%, then it's better to do redo his carotid surgery or stenting. If he came with TIAs and stenosis less than 50%, then you have to treat it medically. If patient asymptomatic after carotid surgery and he has 70 to 99%, they recommend just to do it medical. You can do a surgery, but only after multidisciplinary team review. If patient has a carotid stent and came up with a stenosis more than 70%, then it's recommended to treat him medically and not to re-stent him. What about if patient has carotid stenosis and he's going to go for non-cardiac surgery? Routine carotid ultrasound is not needed and not recommended. If patient on statin antiplatelets, better not to stop it if he has a significant stenosis, and prophylactic carotid surgery before non-cardiac surgery is not recommended. If patient has a symptoms and is going to go for non-cardiac surgery, then ultrasound has to be done. And if he has 50 to 99% stenosis, then it's better to do a surgery before non-cardiac surgery. And if he has a stroke or TIAs within 6 months, and even has no cardiac stenosis, it's better to postpone his non-cardiac surgery at least for 6 months to give the brain some time to recover before his non-cardiac surgery. What about carotid stenosis and CABG? Ultrasound recommended only if he has symptoms, TIAs before CABG within 6 months. If he has no history of TIAs before CABG, you don't need to do an ultrasound unless the patient more than 70 years old and has multiple coronary artery disease. But if patient needs an emergency CABG, then you don't need to do a carotid ultrasound. Just go proceed with the CABG and don't worry about carotid stenosis. What the recommendation for treatment? If patient has a symptom more than 6 months before CABG and he has 50 to 99% stenosis, then carotid endarterectomy is recommended. But if it's less than 50%, then you don't need to do carotid interventions. If patient is asymptomatic and he has 70 to 99%, you don't need to do it before CABG unless only in 2 conditions. If he has bilateral 70 to 99% stenosis, or he has 70 to 99% on one side and the contralateral side is completely occluded. What about common carotid artery stenosis? If patient is asymptomatic, you don't need to worry about it. And if patient is symptomatic, the best way to do angioplasty and stenting. What about dementia? Carotid intervention is not recommended for prevention of the cognition impairment. Second thing, they have a lot of recommendation about vertebral artery disease. If patient has vertebral artery stenosis and he's asymptomatic, you don't need to worry about it. No intervention is needed. But if he's symptomatic and he has 50 to 99%, then you need to consider revascularization either by bypass or stenting. But if you decide to use a stenting, they recommend to use a drug-eluting stent. And after you put a stent in the vertebral artery, they recommend to use a dual antiplatelet therapy, and the level of the evidence is 1C. Combining carotid and vertebral artery revascularization is not recommended during the same procedure, so don't combine them both. So in general, the last word I want to say, always remember that the guidelines is a guideline, is not a legal standard for care of the patient. And guidelines help us just guiding our treatment, but really every patient we should treat it. It depends on his individual symptoms, his comorbidity, age, and the treatment and your expertise. Thank you very much.